Hi and welcome to another video from the CTAD Clinic. My name's Dr. Mike Lloyd and I'm the Clinic Director. In this video we're going to be looking at differences between partial DID or dissociative identity disorder and OSDD, which is other specified dissociative disorders. Now this is the subject of some debate online and certainly within some of the communities about whether it's DID or whether it's partial DID or whether it's OSDD. And partial DID is this strange little sort of subset that really doesn't get used very much but is quite important. And what we're going to be looking at is the different classifications of all of these three things, just to be able to understand why is it that we might arrive at one diagnosis rather than another, and what are the sort of specific elements of that classification that we use as diagnosticians to make that distinction. The key thing though I want to start with is that when it comes to the outcome of a diagnosis, these things really don't make a great deal of difference. So whether you've got DID, partial DID or OSDD, the actual treatment pathway is very much the same. Now the therapist will do slightly different elements of therapy depending on what the diagnosis is, because that's exactly how it should be, but the actual guidelines and the treatment method and the stage treatment protocol for this kind of complex dissociation is exactly the same, regardless of what type of category it comes down to. And also, it's important to note that sometimes during assessment we get a limited window within which to do the assessment, arrive at the diagnosis, and so it might be just a few hours, or for some people it could be much less, but we generally take quite a few hours to look at this. If it then turns out in therapy later on down the line that there are different elements that are presenting themselves which changes the nature of the classification, we do change that diagnosis along the way. So we have to make the diagnosis with the information that we've got at hand, and if that information changes later on down the line, we then make the changes. But again, the actual treatment protocol really wouldn't make a great deal of difference. So just want to make that very clear from the outset. So to start with, we have two different diagnostic systems within which to make the diagnosis, just to further complicate things, because why not? So we have the Diagnostic and Statistical Manual, the DSM-V, and the International Classification of Diseases, the ICD-11. And they both do very similar things, but also slightly different. The easiest approach is with the DSM-V, because the difference between DID and OSDD is really quite straightforward, and it's this: that in DID there is a marked discontinuity taking place between the personality states that arrive. So there have to be two or more distinct parts, and that discontinuity has to be marked, and that marked is in terms of actual behavioural presentation, all those different sorts of elements that are present. And with OSDD, it's less than marked discontinuity. So there is a discontinuity of self, but it's not particularly marked, i.e. it's not particularly visible, it's not particularly outward presenting, so therefore the OSDD applies, where there isn't those two or more distinct personality states that are coming out and basically applying themselves to everyday life in different ways according to the individual. So that definition is quite simple, DID or OSDD, because they don't have a partial DID element to the DSM-V. In ICD-11, that's where things get a little bit tricky, because you've got DID, partial DID and OSDD, and that's what we're going to get into. DID is fairly straightforward. There is an essential feature 1 and an essential feature 2, and these are as follows. Presence of two or more distinct personality states involving marked discontinuity in the sense of self and agency is feature 1. Feature 2, regularly take or recurrently take executive control of the individual consciousness and interacting with others or with the environment. What that means is there are two or more distinct personality states that have agency and control in the environment, either with people or with places, objects, behaviours, things like that. That's pretty simple. Now, with partial DID, the essential feature 1 remains the same, that of two or more distinct personality states. But it's with feature 2 that the partial DID comes into its own rather than DID, and that's as follows. With partial DID, there is one dominant personality state, and any other personality state does not regularly or recurrently take control with agency. So what that means is that in partial DID, rather than DID, any state, any personality, other, part, alter, whatever you want to call them, comes forward kind of through the main essential person or the host, but for very specific and limited protocols of action or behavior. So they're not regularly taking control and they generally don't have agency. It's much more of a reactive thing, i.e. a trigger. So for example, there is generally a person in control of pretty much everything, and every now and then another part is triggered to come out and perform a very limited sequence of actions, and then they retreat as soon as those sequence of actions have been complete. That would give us the partial DID rather than the DID diagnosis. But it's with OSDD that things get a little bit more complicated, and I'll go into that now. And that's because the OSDD component of ICD-11 is a little bit tricky. It's basically, you can call something OSDD if it doesn't quite meet the criteria for DID. So where you've got DID, there's 2 or more personality states can come out and either can be dominant at any one time. In OSDD, we simply don't see that. So there might be many personality states, but we're not seeing anything come forward and taking executive control. So OSDD is very much the drop down of DID in terms of the behavioral and motor sequencing action systems that we see taking place within DID. They are both very complex and both very difficult diagnostic categories for anybody to live with. Simply DID is about the moving forward and OSDD is about the internal states. But we can also know that there can be a bit of a movement because we're not dealing with extremely kind of like contained and held within a specific framework type diagnoses. Things can be quite flexible according to the individual. So OSDD is realistically where we just don't see the elements of DID. It's a lot more than other stuff like depersonalization or derealization, but it's not into that DID category, so we can call it OSDD. And therefore we see that partial DID just sits in between those two things very sort of quietly, because we have to make the distinction with OSDD then, if there is a movement forward, if there is another personality state that can come forward and perform restricted or limited actions, we can call that partial DID. In the DSM-V category, we would probably stick with OSDD for that. We understand that with OSDD within the DSM-V is that sometimes a part can move forward and do something or take control for a very limited thing, but there's not a great deal of agency or choice. In the DSM-V, if we see that element of agency or choice, we're much more likely to start thinking about DID, even in very limited terms. But within the ICD-11, we are really going to go down that partial DID route. I rarely see the partial DID being used, largely because up until recently, the diagnostic classification for dissociation was using DSM-4 protocols. Now that we've got the DSM-5 SCID-D, and that has access to the ICD-11 classifications, we're going to see more partial DID being diagnosed, and that's exactly what's happening within our services. We're now using more ICD-11 criteria because the diagnostic classification for that and the interview schedule for that is much more available to us. So there we go. So we've got partial DID, we've got DID, and we've got OSDD, and depending on which classification system uses depends on where we sort of move and work between. What we have to understand, as stated at the outset of the video, is that it largely doesn't make a huge amount of difference to the therapy protocols, but obviously getting the diagnosis right for the individual remains absolutely important for their sense of self and their understanding of where they're at. So we try our best to get this right. We can be flexible as information changes, but actually our treatment protocols are largely the same regardless of what type of classification we're using. So I hope that's made some sense. It's a lot of information to take in because this is why we spend so long training and getting ourselves ready to make these distinctions as quickly and as usefully and as practically as possible for the individual, but we have to make sure we do it properly. So therefore we have all these nuances and distinctions that we take into account. So I hope this video has been helpful. Please leave any comments in the section below the video as per usual. Do all the liking, subscribing, sharing and all that stuff, which is really helpful for us. Thank you very much. And in between now and the next video, please do take great care.